Thank you, Claudia, and welcome everyone. Welcome to Staffordshire University. It's my great pleasure to introduce Professor Paul Bowie, who's going to be giving the inaugural lecture here tonight. Paul is recognised internationally as a leading researcher and scholar in the interlinked disciplines of healthcare, human factors, patient safety, and quality improvement. His academic research and evaluation outputs involve interdisciplinary partnerships, working with colleagues in the UK, in Australasia, Europe, and Central and North America. He has co-edited a book on safety and improvements in primary care and has a further book in development on the topic of human factors in healthcare education. Paul has published over 180 peer-reviewed articles in healthcare journals as well. Paul's main role is as Programme Director for Safety and Improvements with NHS Education for Scotland, based in Glasgow. He is also Professor of Human Factors for Health and Social Care here at Staffordshire University. He is also an Honorary Professor in the School of Health and Wellbeing at the University of Glasgow and Adjunct Professor at Queen's University in Ontario, Canada. Finally, Paul is an Honorary Fellow of the Royal College of Physicians of Edinburgh and the Royal College of General Practitioners. And the talk that he's going to give tonight is entitled A Life in Patient Safety, My Journey, Reflections and Milestones. Paul, over to you.
Thank you very much indeed, Kevin. Good evening, colleagues, friends, visitors. Thank you very much indeed for coming along here tonight to hear this inaugural lecture. It's fair to say that I'm truly both honoured but humbled at being appointed Professor at Staffordshire University. And hopefully when you hear my story, the journey that I've taken to get here, you'll understand why there's both an honour and a humbleness to that. So I think we'll start at the beginning in terms of reflecting on my childhood before we go into my more formative development years in education and so on. I was born in Greenock, which is in the west coast of Scotland, but both sides of my family are from Port Glasgow, which is the adjacent town. Both of them were renowned for shipyard building, no longer so. But we moved from Port Glasgow to Paisley, about 17 miles inward. Paisley is, for those of you who know, is joined on to Glasgow, more or less. So I moved there when I was 2 years of age, and I've been in Paisley ever since. We were the first from both sides of the family to actually move from Port Glasgow. So my parents made that jump. So it's quite a humble background in terms of living largely until I was about 21 in different council estates in these hometowns, coming very much from a traditional working class family. The greater background is that, essentially, I was brought up by my mother and my two younger brothers. My father left home when I was about 16. He was an abusive alcoholic, so there was a lot to go through in terms of childhood trauma and experiences, which it's in one sense it's character building, in others, it causes kind of long-term pain for all concerned. And so that's a kind of context I think it's really important here to be aware of, before we start looking at what was achieved and accomplished when you encounter the various life chances that, doors open for you, that you have those opportunities from other people who you interact with and who do good on your behalf as such. So in terms of schooling, the local primary school there, St Paul's, and then I went to a secondary school, St Aelred's. And this period here was the traumatic period for all concerned in the family. In terms of my academic outputs in secondary school, I did okay, but in reflection, I think I could have done a lot better given the circumstances. So I think that's easy to work out just now. I scraped in to Paisley College. The first person from either side of my family to ever attend higher education. I studied, as a matter of fact, I didn't even have the minimum qualifications to get into Paisley College, but I don't know how or why I get in, but I suddenly got a letter of acceptance. So I studied applied social studies, but I majored on the sociology of human work, which I didn't realise at the time would become so important in terms of what I do, both in the NHS, but also in terms of what we do here at Staffordshire, with Al Ross and others. After college, I did a postgraduate degree in information management. Later, as you'll see, I did a PhD at the University of Glasgow, and then I did an MSc in applied ergonomics after that at Nottingham University. So at Glasgow, I studied the standard of significant event analyses, which were conducted by general practitioners and GP teams. So that gives you a bit of background context to the kind of formative educational background. Now, in terms of entering the workplace, I think we all know who this character is. So regardless of your political views, Margaret Thatcher, in one strange sense, was responsible for the beginnings of my work career, certainly anyway. So this white paper, Working for Patients, and the white paper number 6 was entitled Medical Audit, was introduced. And the purpose around this was to bring some accountability to the medical profession in terms of the expectation that they would provide evidence of the quality of care and service that they delivered. And so what happened as a result of that, well, certainly in Scotland, but I think across the UK, if I remember as well, is that new roles were created to support the implementation of medical audit, so to help and assist medical practitioners to deliver on these obligations, these expectations, to study and improve the quality of care that they provided. And so I luckily, after my postgraduate diploma, got a role at Inverclyde Royal Hospital as probably one of the first medical audit support officers in Scotland and in the UK. And this was around 1992 this happened. I also worked after 6 or 7 years there, 7 years there I think, briefly for 6 months in United Arab Emirates in a senior quality advisor role, and then as head of clinical governance when I returned from there in Stirling Royal Infirmary up until 2000, January 2000. And so, as you can see here, there's a career progression in terms of more senior roles, much more experience, and so on and so forth. I thoroughly enjoyed it. Absolutely fantastic experiences working in a range of projects across all care sectors, all professional disciplines, working with some great people and great teams. You get a fantastic experience from that. You're also seen as a neutral in the type of role that we do. And I know Helen here interacts with a lot of people who work in quality and safety advisory roles throughout the NHS. And they're the kind of roles that my role essentially set up and evolved in that sense. You're seen as neutral because you have no skin in the game in terms of any demarcations or professional boundaries. And so you can work freely with everybody, without anybody judging you in that sense. And because you often bring a sense of logic and rationality and an ability to capture data, analyse data, write and report, you essentially are doing the donkey work for a lot of clinicians around how we improve, how they understand and study and improve the quality of care. So that's my kind of working background. What happened, though, was I was encouraged by a medical director and the director responsible for audit to begin to think about maybe publishing some of these outputs because they were impressed with the quality of the reports that were being written on a variety of different topics. So when I spoke to the clinicians I was working with, they agreed. They thought this was fantastic. Yeah, why don't we try? So there was a few journals beginning to appear which were dedicated to publishing evidence around the quality of care. And also most healthcare journals pivoted to having sections within the journals around the quality of care. So there was lots of opportunities to submit to various journals. And there's just some of examples of the types of projects that we're working on and topics that we provided some evidence for in terms of future publication. Now, I'm not saying it, they're all very descriptive and they're all low quality, but it gave me the taste for taking a scholarly approach, an academic approach to the type of work that I was doing. And so, to some extent, I harboured an ambition maybe that I could potentially one day be much more scholarly, be a researcher, be an academic. I did think about it, but I laughed at it because I thought it was an impossibility. I thought I'm better off in the NHS, better off, progressing my career in that sense. So those were the three areas, the three district general hospitals that I worked in. So by this point, I had maybe, maybe 10 to 12 years of experience. I was travelling to Stirling every day, which is a good, it's a good journey and a bit tedious. And this job in Glasgow came up, working in audit in the Department of Postgraduate Medical Education, the West of Scotland Department of Postgraduate Medical Education, based in Glasgow. And so I successfully interviewed, got the job, and these two chaps here, Professor Stuart Murray and Dr. Murray Loch, so their names are a bit interchangeable there. So both of them were GPs, so Stuart was the postgraduate dean, and Murray was associate postgraduate dean. Why is Murray in a silhouette? Because he left the organisation 5 or 6 years ago, and I can't understand this. This guy was the president of the Royal College of GPs in Scotland, and I cannot find a photograph of him anywhere when you Google him. But these guys were utterly fantastic to me. The PhD that I mentioned, I didn't pay a penny of. It came from funds that they had. I did it as part of my job. They also funded my MSc later on. They created an academic environment where risk-taking was encouraged, learning shared, hugely supportive to each other. It was just manna from heaven to be working in that team and to be, you couldn't say you were line managed by these guys. They just trusted you so much. You had the freedom to essentially work as you saw in support of the greater goal of creating resources, studying the area of audit and improvement as part of medical education as a whole. And so this is a classic example of a life chance, an opportunity, a gift horse that really set the foundation for the rest of my career in that sense. So I'm eternally grateful to them and to the organisation. So that the Department of Medical and Dental Education was based at the University of Glasgow, but subsequently, as we'll see, became NHS Education, a part of NHS Education for Scotland. So at that point, they asked me, what did I want to do my PhD in? So significant event analysis was one of the expectations that GPs had to provide evidence for their medical appraisal and subsequently for revalidation. I should have added that Stuart Murray, the professor there, is both famous and infamous. He's the guy who led the development and the implementation of summative assessment for general practitioners. So before this system was created, which is now just standard, you could easily transition as a medical practitioner to be a GP. Now you've got to train and be assessed and pass that assessment to be a GP, so there's a standard in place. And I joined the department when this was being piloted, and this guy was absolutely vilified. And so later in his career and later in my career, he showed me the scores of letters that he kept in his drawer from irate GPs, really upset at the fact that they were having to go through some type of summative assessment process. But of course, he was thinking ahead, he was light years ahead, and it's even been built upon now, it's just become routine and accepted practice. So they asked me, what did I want to study? And I said, significant event analysis. Had a real interest in that. And again, in terms of a future human factors career, and having studied human work at university, these were just perfect matches. We were strongly encouraged when undertaking a PhD in that department to publish as we went. The idea being that when you sit down for your viva, you've got peer-reviewed publications already in the bag, and so therefore it becomes easier to defend in that regard. And it's something I try and encourage with our PhD students today. And so there's some examples of the outputs there. And I would go on to do further postdoctoral work in significant event analysis. It's now enhanced significant event analysis. It's now spread to all the other primary care professions. And indeed, the basic principles of it are now used in team-based meetings in hospitals around mortality and morbidity meetings and case conferences and so on. And I'm actually still working in this area, as I said. So once the PhD was complete, so I'm looking at Sarah Jane here, who I forgot to thank at the beginning, incidentally, because she strongly encouraged me and pushed me to apply for this when I was a bit more sceptical about it, so apologies, Sarah Jane, sorry. But Sarah Jane and I often have a standing joke about the type of research that I do, but this was the first proper research programme I've ever been involved in. So it was a European-funded study known as the Linnaeus Primary Care Patient Safety Study, led by the University of Manchester, and involving 11 countries around the EU. I think it was 10 work programmes. And in Scotland, we were given the work programme of looking at the safety of laboratory test ordering and communication of results in primary care. Absolutely fascinating subject, a real social technical problem in terms of ordering a blood test, receiving it, processing it, acting on it, and communicating the outcome to patients. There's basically 8 generic steps to doing that, but the holes between each of the steps are incredible. So it's quite a significant, it can be quite a significant safety issue. And so you can see there, I think I was beginning to step up the mark in terms of the quality of publications in more high-status journals. The good thing is that, unlike university colleagues, we weren't being assessed on where we were publishing. What we are more concerned about is building an evidence base, around the utility of what it is we're looking at. Are these things acceptable? Is it feasible? What kind of impact are you having? And so we always had this evidence-based utility model in mind, and as I said, building that evidence base, taking a scholarly approach, but less so on the impact factor of the journal. It's a bit different now. So from there, and this is getting a bit scattergun now, what I've done is divide up the types of research and evaluation that I've been involved in, and I'll skip through these quite quickly. But I started to get a name for myself as a patient safety researcher. I would say that the team that I was involved with was only a small team. We're probably at one stage, and this is a self-assessment, we're probably the leading primary care patient safety team in the world, largely because we're probably the only one. 2 or 3 others came on board, and we did collaborate with them, Canada and Australia, in England, at the University of Manchester. And so we all learned from each other. So I think we were probably one of the first, and that's why we get a name for ourselves in that regard. So you can see here that there's a mixture of what I would call health services research, so working to solve problems in the service, but also look from a safety point of view, but also looking at it educationally. So much more of a medical education role around patient safety as well. And so that, although we did have research teams as such, you can see there's a great deal of diversity there. But there was always a purpose, because they played into separate things which were a priority, not necessarily for me, but for others, and which is why. So I just pivoted to where the research need was required at that time, and responded positively within the department, within the team. And so this is the bit when you become a bit of an arrogant scholar. You think, okay, I've made a name for myself here, I've published research, I'm reasonably well known in this particular area. So you begin to think about, let's call them thought papers, opinion pieces, thinking, I know stuff here, I think we should be doing X, Y, and Z. Let me try and write something academic around that, and try and, be a provocateur, challenge the existing status quo, suggest where we need to go, and myself and Al Ross, to a large extent, do that now as well from a human factors perspective. But the thing is, these things are received positively. You feel a bit of a fraud initially when you're doing it, because it's, you know, even though you think these things and you discuss them with colleagues, put them on paper and send them to your journals is quite an anxiety-induced next step, because you don't know how they're going to be received. So Helen and I were speaking earlier. For those of you who don't know, in terms of the various initiatives that ongo in the NHS, quality improvement, as it's known as now, is king. Okay, so for those of us who work in patient safety, for those of us who are trying to build capacity and capability in the workforce around human factors, one of the more significant blocks to this, and it's not a purposeful block, but it's just it just makes our job much more difficult, is the focus put on quality improvement, and the focus that, you know, that quality improvement is a bit of it's a bit single-minded in terms of the concepts and the methods that it embraces, whereas myself and the team at Staffordshire and elsewhere, the other colleagues we network in the UK, see quality improvement much more as a broad church, and that it should embrace all types of philosophical positions and methodological approaches and so on and so forth, largely beyond the kind of largely singular approach that's taken just now. There might be counter-arguments to that, but regardless, we now have to, in the position of saying, well, we can't replace quality improvement, we're certainly not looking to do that, but we can add value from a human factors, patient safety science perspective. We can add value to what's been done, and that's a large part of our focus currently, in the past and today. So I just want to show you some examples much more explicitly of being bold enough to say, no, we're doing human factors research. And again, there's diversity here. There's different clinical contexts, but essentially the link is that we're often testing similar concepts and similar methods being applied in the real world. So, for example, you'll see quite a lot of publications with Al Ross, who's in the audience, on what's known as Safety 2 or resilient healthcare, or the functional resonance analysis method, FRAM, which comes from this sub-branch of human factors, resilient healthcare. And so we're trying to test these things out, and we're making traction with them because it's getting noticed in the quality improvement world. People want to know more about this. This is potentially a more meaningful way of understanding highly complex socio-technical systems, and therefore informing how we design safety improvement interventions and so on and so forth. And similar to what we did with patient safety, we're putting our head on the block. You know, so we're making scholarly arguments about the need to build capacity and capability in human factors in the healthcare workforce, about the need for embedded clinical specialists in clinical practice, and that how this might look. What will this look like, or should look like, from a policy perspective, from an educational perspective, from a research perspective, and an everyday service practice perspective. So we're beginning to see ourselves and be viewed by others as being leading lights in making these arguments about what needs to be done and how it needs to be done. The issue we have is, how do we influence politicians? How do we influence national policymakers in this regard? Because in my mind, that's the only way we're going to get true traction around the introduction of human factors into healthcare in a routine way. I should say, incidentally, that human factors approaches are mandated and regulated in all safety-critical industries, other than healthcare, which is arguably the most complex human work endeavour that's ever existed. And yet, our counter-argument is we don't treat it like that. And that's one of the points that we make. Again, just to give you examples of work that I was heavily involved in, and I don't know whether I'm embarrassed to say this, because, you know, it could be seen as quite an insensitive thing to say. We all endured COVID-19. It was a torrent, tough time for many, but it was the most productive aspect of my career. You know, as a human factors specialist, involved in many different networks, from day one when I was working from home, I was pulled into so many different projects, both in my own organisation, in the UK as a whole, but also across the globe. And so we get involved, as you can see there, in many different initiatives that we rapidly got off the ground. And we worked collaboratively and dynamically in ways that were just a joy to behold in terms of how everybody responded. And we just thought, why can't this just be the routine? We need to sustain this. Wouldn't it be wonderful if this was what work and research and academia actually looked like in the real world? But alas, we've slipped by now back into the old ways, where rules are rules, adaptation, risk-taking is maybe not as encouraged as it should be. And there's more examples. So a big piece of work I was involved in was looking at the design of facilities around how we vaccinate safely for both patients and for staff also as well. The big one there about the ventilators, I don't know if anybody can recall the way the disease, or the way we thought the disease was evolving at that point in time, was that we don't have enough ventilators in the country. We're going to be overwhelmed with the demand when this really hits. And so that was the way of thinking. So we as a team at the Chartered Institute and in our various networks, we responded quickly to that, because the idea then was that novel manufacturers of ventilators would be expected, or were actually volunteering, but would also be expected to create them. But the point was that they had no recommendations or guidance on how to do this in a safe way. Because it's a fairly straightforward thing, I'm led to believe, engineering-wise, to create a ventilator, but there must be safety mechanisms within that. So from a human factors design point of view, we created this guidance very quickly. That was our very first output. And it was led by Professor Sue Hignett at Loughborough University so brilliantly. But thankfully, it was never needed. So we got it to parliamentary level. It was known about, it existed, but it was the first example of the type of impact that we could potentially have. And as I say, we began to do that. I was brought in within my organisation in Scotland to look at a whole variety of different things, including, as I said, the vaccination centres themselves. So it would be fair to say that over time, in terms of, you can see this bigger picture of research, as academics, as scholars, your views change. One of the areas that I focused on and became, with my colleagues, very expert in was the psychometric development and implementation of safety climate measurement instruments for the care workforces. So actually, measuring the concept of safety climate in a workforce. And so we became really good at following best practice from a research point of view and how this should be done from the psychometric perspective. But fast forward 10 years after investing so much time and energy and money in this, after these tools, validated tools, being implemented nationally and internationally in various safety programs, we couldn't really see any difference that they were having. So the holy grail of measuring safety climate within a workforce is, can you link it to outcome? So if I said to you, let's look at the mortality and morbidity statistics in an ICU, an intensive care unit, in one hospital, and then across another 300 sites, let's look at the statistics there, and then say, can we align them with the safety climate measure in the workforce? So you've got a more negative safety climate measure. Is there an association between that and higher mortality and morbidity statistics? The problem we were having in the work that we were doing was that the statistics we had, the data we had, was not of good enough quality to make those types of associations. My team have got the largest collection of data on safety climate in primary care in the world, and we've never published it. because it's just hugely descriptive. It doesn't tell us anything. We could have predicted what it said beforehand. And so the pivot here is that measuring something as elusive as safety climate is maybe not the best thing to do, despite the existence of 350 such instruments, which you find when you search the evidence base, despite the fact that they're widely used, and despite the fact, as my PhD student there from Kuwait, when she did the systematic review, looking at assessing safety climate in acute hospital settings, found that of the 350, 5 were actually satisfactory in terms of the adequacy of the psychometric properties and approaches that underpin those instruments. So essentially the rest of them are pretty invalid in lots of different ways. So what we did was we pivoted to a more qualitative approach, because what we found in our research was that teams disregarded the numbers they gave us, but really valued the opportunity and the protected time to sit together to discuss and reflect on the prevailing safety climate within their team and their organisation. And so we went down a more qualitative route as a result of that. So our views have changed over time. And the same with the idea of never events. So never events are serious patient safety incidents which are judged should never happen. So, for example, I don't know, operating on the wrong patient, removing the wrong limb or the wrong organ, retained surgical swabs and so on. But as Al and I will discuss with you all day, from a safety science perspective, this doesn't make sense. And so the point is that in highly complex social technical systems, things will go wrong. Things do go wrong. And you can't put a measure on it. The idea of chasing zero harm is a pipe dream from a human factors safety science perspective. Now, that may be unpalatable to say, especially to someone in healthcare, to politicians and patients and families and the public. But it's the reality of the complex world we live in. And so on one hand, you can argue it's a false hope to offer the public the idea of zero harm. We need to think about risk in different ways, and there's alternative strategies that you use in other high-risk industries. So an alternative strategy is we need to understand and manage risk to be as low as reasonably practical, because we cannot eliminate it all in the way that the never-event concept focuses on. And so we were involved in a lot of never-event developments, not because we agreed with the principle, but because in primary care dentistry and general medical practice, I was getting feedback from them that we're not really that safety critical. So when you go and ask them, using consensus building methods, what's the most safety critical things that can happen? Then you get an eye-opener. You use consensus building methods. You say, well, we can now come up with a list of 8, 9, 10 things that the GP teams think should never happen, really serious safety incidents. And you know what? When you survey them, they do happen. So our point was to use the never event concept as a way to demonstrate how unsafe, in a serious way, certain care sectors could be. I just want to speak briefly about all this research. It led to various educational developments, interventions as such, and so you can talk about, well, did any of this make any difference? So I can say to you that lots of our outputs are in various specialty training programmes, undergraduate, postgraduate courses, the Scottish Patient Safety Programme, various quality improvement toolkits. So, there is an implementation element to this, which I'm pleased to report. And also, the fact is that we've changed views and perspectives amongst organisational leaders, national policy makers as well, senior educators, senior leaders who are pivoting much more towards adopting a more modern safety science human factors approach to the tasks that they have to perform or the initiatives that they have to lead on and implement as such. The best bit for me about being involved in this type of work is supporting and advising other people. And here we have 5 medical colleagues whose PhDs I co-supervised and published with, all friends. So we've got Dr. John Mackay, who recently retired, was an associate postgraduate dean. We've got Dr. Carl DeVette, who is now the top medical doctor in Queensland, Australia. Dr. Duncan McNabb, another associate postgraduate dean. We've got Gide, Al Salim, who is now a director of the Ministry of Health in Kuwait, and we've got Samantha Fell, who's a director at Spectrum Healthcare in the United States of America. So this is the bit that gives you, a great amount of satisfaction and a wee bit smugness to some extent. Brilliant individuals to work with, and it's just so, and did great PhD work, but just so wonderful to see where it took them in their careers as well. So this is an aspect I really enjoy. And obviously we've got a number of PhD students here at Staffordshire and the other areas I work in. And as I say, it's a bit I really enjoy. When you get old, when you start to get old, for some of you in the room will know that, then people will ask you to do things. So, I'm pleased to say and proud to say and completely surprised to say that I got an honorary professorship at the University of Glasgow for the last 10 years. I've been a visiting professor in the Department of Medicine in Sydney, and I've got an adjunct professorship at Queen's University in Ontario in Canada. I'm an ambassador for the Clinical Human Factors Group. I'm a sector lead in patient safety at the Chartered Institute of Ergonomics and Human Factors, and I'm a hub leader at Helen's Patient Safety Learning online site. And I'm embarrassed to say that I've done the square root of nothing for her since I took up that role, but we will amend that. And the book that was mentioned earlier, 2014, really proud of that book. 38 chapters, 22 different authors, not a single person failed to deliver. If anybody was late, it was me. It was just wonderful. I couldn't believe when people thought you were off your head trying to put together a book like that. But it took 2 years. And as I say, everybody engaged with all delivered in terms of co-authorship. So I'm really proud of that. And now here I am at Staffordshire University. How did I get here? Unfortunately, Mike can't be with us tonight. So this is another life chance, another open door, another opportunity. And that opportunity took place on a Saturday morning. When I was on Twitter, I'm not a big Twitter user, but I just happened to be on, and I saw Mike promoting the new MSc in Human Factors for Patient Safety here at Staffordshire. I didn't know Mike, didn't know anything about Staffordshire, didn't know anything about the MSc, so I just tweeted to him, fantastic, because that's a big part of what I'm involved in, is trying to build that capability. Fantastic news, well done. To which he replied, thanks, do you want a job? And so on the Monday morning, we had a chat. And then subsequently, I was employed. And so here I am today. And so it's brilliant to be part of the team with Sarah Jane and colleagues. We've got the MSc in Human Factors. I can still draw on my other roles in NHS education and in the Healthcare Safety Investigation branch. So we've got that experience from other areas, other workplaces, other colleagues that we can bring in to the university as well. And so we want to focus on not just developing the workforce in the NHS academically from a human factors perspective, but also in faculty development internally within the university, so we can embed human factors concepts and approaches across health and care education. And of course, I'll have a minor research role, but certainly Sarah Jane and I'll lead the way in terms of future health services research. So as I said, a great privilege, an honour. I'm extremely humbled to be here. Thank you so much indeed for coming along this evening and for listening. I've noticed nobody fell asleep. There was no eyes shut, so that's really pleasing. That was one of my metrics. So thank you very much indeed. I'm happy to take any questions at all over any of them. Hi. So I should have explained that, so apologies. So I made a great assumption there. So human factors is a science discipline and a profession. Okay, so have you heard of ergonomics? Yeah, so ergonomics and human factors are synonymous. They are the same discipline. Okay, but it just depends what part of the world you're in, whether you call it human factors or ergonomics. And so it's about design. It's about understanding, in the healthcare context, about understanding complexity, and designing workplaces, whether it's a physical environment, whether it's care work processes, whether it's work procedures, you name it, medical devices, digital IT, designing it from a human factors science perspective, i.e. to make it easier for people to do the right thing, to make it safer, and so on and so forth. So that's the human factors discipline. Thanks for asking that, and apologies I never clarified that.
Any other questions?
Hello, Helen from Patient Safety Learning. Great that you've committed with witnesses to do some more work for us, so that's fantastic, thank you. So why do you think, as you said, politicians, policy makers, and I would add organisation leaders have been so resistant to the insights from human factors and ergonomics?
I think I don't know whether it's resistance or, ignorance, but not in a kind of a negative sense. We don't know what we don't know. So there's strong interest, as you know, in human factors in healthcare from the WHO, from the various royal colleges, the professional bodies, even the clinical regulators. There's real strong interest there. But what they lack is subject matter expertise. They've got, a few passionate, novices who are really keen to push it. And so that possibly doesn't help in that sense, because they can't give a united, coherent message to policymakers and others about what needs to be done. And the professional body, the Chartered Institute, doesn't just represent healthcare, it represents these other safety critical industries like transport and the petrochemical and the nuclear industry. But it's tiny, so it's not well known or recognised within the behemoth what is healthcare in the UK. So I think that's a combination of reasons as to why we're not made traction yet. It's going to be people like yourself, Helen, I think, in terms of recognised leaders who can potentially, along with the people you net with, who can potentially make influential moves in this regard.
Hello.
Hi.
Odwayo Klaoleo Mulade is my name, but I ask people to call me Hayo, and I do apologize for coming in late. But I think I came in at a time when you were presenting something that I can see that you are very passionate about and very interesting, which talks about the culture of safety, the measurement of the climate of safety. And some research were done and validated. I've got some background in quantitative research, and the validation, I just want to find out, because there is something that is called some theories of objective measurement around validation techniques. I don't know under what validation were those psychometric properties discussed, whether there is inclusion of objective measurement in those psychometric properties discussed.
Yeah, so in terms of the measurement of them, so one of the characteristics of that needs to be considered in the development of these tools is the theoretical underpinnings of it. So all part of safety sciences informing the development of this particular tool, and that's before you start thinking about the validation of the content and the rating scale that you're going to use, and then testing whether the measurements that you're getting back make sense when you feed them back to users as well. And when we mean users, it's not just the people in the workforce, but the people who are going to use the data. And that can be researchers, it can be policymakers, it can be leaders, and so on. So there's a very well trodden path from a psychometric point of view about how you do this. So the two instruments that I cited there, the one for dentistry and the one for general medical practice, are cited as number one in the various systematic reviews of these instruments that have been done in terms of the quality of the psychometric development and testing that took place. And it's not to take credit for that, because all we did was follow exactly what best practice says should be done. It's clear that researchers throughout the world, when they're involved in the other work, don't do that. They partially abide by some of the guidance around that. But as I say, in terms of the context that we applied it in, we obviously never thought it through too much in terms of how you link the data with other outcome data, because that's the holy grail of measuring safety climate, is to align it, to look for associations, even correlations between that and other data sets, and we found that extremely difficult to do. So therefore it just gets used as a descriptive tool. 50% of the workforce think, the workload's too high. That's the kind of level you're getting back, and that's pretty meaningless, because I told you that beforehand. So I don't know if that answered your question. But Sorry, thank you.
Paul, I have a question. And
Sure.
it's about audit, because some of what you've been describing in the work that you've done over your career has been very much about a kind of approach to auditing things within the healthcare sector.
Yeah.
The career you charted there over the last 30, 35 years or so, same sort of time frame as for my career in higher education, is very much sort of aligned in timeline with the rise and the emergence of audit as a very common feature of our daily lives. You know, where once audit was something that accountants did to check people were spending money and doing that, it's now pervasive across everything in every sector. So I just really had a question about why you think that is the case. Why is it that we see audit as such an important part of modern life in this country and across the world indeed?
So I can speak it to that. It's a great question. You can speak to that from the kind of healthcare perspective in general, but more specifically from the medical education perspective. Because if you begin auditing your practice, then, and this didn't happen before routinely, then you're putting your head above the parapet, okay? Because you're putting yourself open for others, peers, patients, the public, to see the level of your professional practice in a specific area, potentially. And I think that can only be a good thing. Whether audit in the way that it's described and the way that we help develop it is the best way to do that, I'm not sure. So another example was significant event analysis. So providing evidence that something's gone wrong, there's been a patient safety incident in your GP team, and you've taken the time to identify it, to apologise, to reflect on it, to analyse it, and to learn from it. That's a great example of reflective practice, of learning, and providing evidence of your professionalism as such. So audit can do that as well. So both of them, I think, play into that scrutiny expectation, the governance expectation, but also plays into your professionalism, because you can use it as evidence to demonstrate your professionalism. So I'm looking at these as not as a kind of audit instrument as such. I'm looking at them much more as something that's designed and developed around sound educational principles. But it's also multifunctional, because you can use it as evidence, as I say, to be revalidated, and to prove that you are a good doctor, or you're a good GP, a good pharmacist, and a good dentist as such. So I think that's why. The problem is it's done pretty poorly, but that's another straight issue.
We have time for one more question, if there is one. Brilliant.
Thank you. So I was going to ask a question about how specific the audit for significant events are in clinical practice. So is it that it's how many events that class as a significant event that you are evaluating in a department, or is it what caused it? Because when it comes to new therapies, are we including them in what generally happens in that department, or are we isolating them if it is a completely new therapy that's had a significant event?
So we're looking more at iatrogenic harm.
So for example, if we bring in a new cancer therapy, but it accidentally got infused into the wrong patient and they had a death because of it.
Yeah.
So would that be an isolated thing that you would audit, or would that count as a significant event in that department that happened?
So I don't know if clinically to make a judgment on that one, but a simple example might be in general practice. You know, you could be appropriately prescribed antibiotics for an infection. Those antibiotics will work, but they may give you an upset tummy. So have caused harm to you as a result of giving you the antibiotics, but it's the right thing to do. So that wouldn't be classed as a safety incident. So a safety incident might be, I was talking about laboratory test results there. So there's an important test that's come back. It's been red flagged, it's been serious, potential cancer sign here, but it's not been adequately communicated to the family. There's been an assumption made that somebody's communicated it, but it's not happened. And so the patient comes back 2 or 3 months later, we noticed that, things have now advanced, and that patient never got that notification in the first place. That would be seen as a serious safety incident, and that must be investigated as such. We need to understand how and why that went wrong, and what we can do to mitigate or or minimise future risks around that. So typically that's what the GP team, that's how they would respond to that. What I'm interested in is the quality of that response. You know, so they would use as a proxy for that, they would have a written report on the entire incident, what they think influenced it, what they're going to do about it. And so myself and others would essentially peer review that and provide feedback from a safety science perspective on what was done well, what was missed, and so on and so forth. And that again is another example of audit, an external scrutiny. So to be prepared to send something as sensitive to that outside the workplace to be reviewed by somebody else and then provide feedback is a form of quality assurance as well, not just for the GP team but for the public. You know, the standard of these things has been monitored to some extent. Hope that answers the question.
Thank you very much, Paul. Thanks for a really fascinating talk. Can we show our appreciation once again?
Thank you. Thanks once again, really appreciate it.
Thank you very much. And just to let you know that the next inaugural professorial lecture that will be held in this room will be given on Tuesday the 30th of April, and that will be delivered by Professor Annabel Kiernan, our Pro-Vice Chancellor for Academic. And the title of her talk is Destination, Higher Learning and Social Change. So I hope to see some of you there. Thank you for coming. Thank you.